So, if a 20-year-old rugby player and like a 60-year-old weekend golfer
Hmm.
walk into A&E and they both have the exact same first-time anterior shoulder dislocation,
Right.
your instinct, might just be to reduce both of them, put them in a sling, and send them to the fracture clinic in a week.
Yeah, that's standard.
But treating them the exact same way could actually permanently cost that 60-year-old the functional use of their arm.
Completely. I mean, the reason why comes down entirely to the underlying mechanical properties of the shoulder.
Exactly. And, you're probably listening to this deep dive while driving to a shift, or maybe you're just trying to knock out some chores so you don't have your notes in front of you.
Right. You're on the go.
But your mind is squarely on the FRCS trauma and orthopedics exams. So our mission today is to build a mechanical model of the upper limb that's so robust you just don't have to memorize isolated facts for the boards.
Because the shoulder isn't just a collection of tissues, right?
Mm-hmm.
It's this incredibly elegant but sort of precarious mechanical suspension system.
Suspension system, right?
Yeah. Yeah, and if we understand the vectors and the forces at play, well, every diagnostic test, every pathology, and every surgical indication just becomes a logical consequence of that machinery breaking down.
Oh, that makes so much sense.
And the core organizing principle, like the thing that has to govern how you think about the glenohumeral joint, is the rotator cuff is a dynamic force couple.
A dynamic force couple.
Right, its overriding biological mandate is to keep the humeral head perfectly centered on the face of the glenoid.
And because that glenoid is essentially, well, it's a flat saucer, right? It's not a deep bony socket like the acetabulum down in the hip.
Exactly, it's flat.
So it relies almost entirely on that dynamic tissue to prevent catastrophic migration. I mean, if the centering mechanism is intact, the prime movers, like the deltoid, they can operate safely.
Right, but when the rotator cuff fails, the humeral head drifts.
Mm.
And which way it drifts and what it crushes in the process, well, that dictates the exact pathology you're dealing with.
The altered kinematics basically tell the story.
Precisely.
Yeah.
If the head translates superiorly,
Yeah.
you face one set of surgical problems. If the soft tissue gets pinched against the coracoacromial arch, you have another.
Right.
And if the impingement is intra-articular, like on the posterior superior labrum, that is entirely a different mechanical failure. So same joint, but completely different vectors of pathology.
Wow. Okay. So because you're revising on the go, we've designed this deep dive specifically for auditory memory. We're going to intentionally state every key structure, every specific clinical discriminator, and every physical test twice throughout our discussion.
Yeah, auditory repetition is key here.
We won't say things like, let me repeat that, We're just going to organically ensure the key FRCS data points hit your ear twice. And we'll also run through 2 mid-episode consolidations.
The goal is for the biomechanics to really click. So let's start with the foundation of that centering force couple. We're dealing with 4 distinct muscular units that blend into a continuous tendinous hood over the humerus.
Right, the SSS muscles. SITS, that's supraspinatus, infraspinatus, teres minor, and subscapularis. So again, that mnemonic is SITS, supraspinatus, infraspinatus, teres minor, and subscapularis.
Spot on. Now, before we look at the vectors they create, we really must lock in their innervation. From a neuroanatomical standpoint, the rotator cuff is overwhelmingly innervated by the C5 and C6 nerve roots.
The C5 and C6 nerve roots.
Yep.
Right, so if you have an upper trunk brachial plexus injury or, say, a cervical radiculopathy at C5, C6, you're going to see a catastrophic failure of this centering mechanism, totally independent of any tendon tear.
Yeah, that's a critical distinction for the differential diagnosis.
Hmm.
But assuming the nerves are intact, let's look at the biomechanics of abduction in the coronal plane.
Okay.
There's this old, highly pervasive myth taught in early medical school. It says that the supraspinatus only initiates the first 15 degrees of abduction, and then it essentially goes quiet while the deltoid takes over.
Wait, I was definitely taught that. Like, the textbook diagram always showed the supraspinatus pulling for the first 15 degrees and then, just handing the baton to the middle deltoid. Are you saying that's mechanically false?
It is entirely false. And relying on that myth will absolutely lead you astray in the exam.
Oh, wow. Good to know.
Yeah, EMG studies and dynamic vector analyses show that the supraspinatus works as a force couple with the deltoid across the entire range of abduction. It remains active through the full arc. It does not clock out at 15 degrees.
So the supraspinatus acts as a force couple with the deltoid through the entire range of abduction. But why? What is it physically doing at, say, 90 degrees or 120 degrees if the deltoid is the prime mover?
Well, think about the geometry of the deltoid. It's this massive, multi-pennant muscle wrapping around the outside of the shoulder, right?
Right.
When the arm's at the side, the deltoid's line of pull is almost completely vertical. So if the deltoid contracted in isolation, it wouldn't lift the arm outward. It would just shear the humeral head straight up, slamming it into the acromine.
Ah, I see.
So the supraspinatus, which lies horizontally over the top of the joint, it acts as the vital countermeasure. Its vector pulls the humeral head medially, compressing it directly into the glenoid concavity.
Okay, so while the deltoid is trying to pull the humerus vertically, the supraspinatus is simultaneously pulling it horizontally right into the socket. And the resultant vector is what allows the arm to smoothly pivot in abduction without superior migration.
Exactly. It creates a stable fulcrum, but, that only manages the forces in the coronal plane. The shoulder operates in 3 dimensions. So we also have to account for the transverse force couple, which manages the axial plane.
Right. This is where we look at the front and the back of the joint. We have the subscapularis anteriorly, inserting on the lesser tuberosity.
Yes, and balancing it posteriorly, we have the infraspinatus and the teres minor, inserting on the greater tuberosity. These structures are engaged in a constant, highly calibrated tug-of-war.
A tug of war?
Yeah, the anterior pull of the subscapularis perfectly balances the posterior pull of the infraspinatus and teres minor.
Okay, so the subscapularis perfectly balances the infraspinatus and teres minor. So it's essentially like a suspension bridge or, I don't know, a tent pole held upright by tension guy wires.
I love that analogy.
Right. If you have a guy wire staked in the front and one staked in the back, the pole stays centered. But if you sever the front wire, the subscapularis, the entire structure loses its center of gravity and just shifts backwards.
That is the exact mechanical consequence. And this is why it is so heavily tested. If a patient sustains an isolated tear of either the subscapularis or the posterior cuff, the primary issue isn't just weakness in internal or external rotation.
Okay, what is it then?
The critical failure is that the front-to-back balance is destroyed, causing the humeral head to immediately decenter and become unstable on the glenoid.
So destroying the front-to-back balance causes immediate instability, not just a loss of torque. If you only remember one thing from this foundational anatomy, it's that the rotator cuff is a centering force couple. The supraspinatus is active through all of abduction to resist superior shear, and the transverse front-to-back balance keeps the head compressed on the glenoid.
Spot on. So now that we have the mechanical baseline, let's look at what happens when this tissue begins to fail, which brings us to tears, dislocations, and the ultimate end stage of cuff tear arthropathy.
And this ties directly back to the A&E scenario we started with, the 20-year-old versus the 60-year-old with the anterior dislocation. What exactly is the epidemiological rule we need to apply in the exam hall?
Well, the exam heavily tests your understanding of tissue biomechanics over time. Rotator cuff tears increase exponentially with age due to microvascular changes and collagen degeneration.
Makes sense.
Therefore, the internal damage caused by a dislocation is entirely age-dependent. If a patient is over 40 years old and suffers a first-time anterior shoulder dislocation, there is a greater than 30% incidence of an associated rotator cuff tear.
Over 40 with a dislocation equals a greater than 30% incidence of a cuff tear.
Exactly. And if that patient is over 60, the incidence of an associated rotator cuff tear alongside the dislocation skyrockets to 80%.
Wait, 80%. Over 60 years old, the incidence of a cuff tear is 80%. I mean, that completely changes the management protocol?
It has to. Let's look at the 20-year-old rugby player. Their rotator cuff tendons are robust, highly elastic, and mechanically superior to the bone cartilage interface.
Okay.
So when the humeral head is forced anteriorly out of the joint, the tendon doesn't yield. Instead, the force shears the anteroinferior labrum and the capsule right off the glenoid rim.
Which gives us the classic Bankart lesion. The labrum fails because the tendon is actually too strong.
Precisely. You hunt the labrum in the young patient, but in the 60-year-old, the labrum and capsule have often become stiffer and more fibrotic. Meanwhile, the rotator cuff tendons have endured, 6 decades of microtrauma and vascular watershed ischemia.
Ah.
So when the humerus dislocates, the tendon is now the weak link in the chain. The tendon ruptures before the labrum detaches.
Meaning in the older patient, you must hunt the rotator cuff tear. You can't just reduce the joint, confirm it's unlocated on the post-reduction x-ray, and send them home for a month of rest.
No, if you do that, you are courting disaster. You must evaluate for a rotator cuff tear with prompt MRI or ultrasound imaging. If you miss a massive acute cuff tear in a 60-year-old and let the tendon retract, let the muscle undergo fatty infiltration for 6 weeks in a sling.
You're in trouble.
Yeah, you may permanently miss the surgical window to actually repair it.
Okay, so let's talk about diagnosing that tear radiologically. An MRI is the gold standard, sure. But historically and frequently in exams, we see questions regarding arthrography.
Very true.
If we inject contrast dye into the glenohumeral joint, what is the pathognomonic sign of a full-thickness tear?
You are looking for the Geyser sign. In a healthy shoulder, the rotator cuff forms a watertight roof over the glenohumeral joint, completely separating it from the subacromial bursa above.
Right.
So if you inject dye into the joint, it stays in the joint. But if there is a full-thickness tear, a complete transmural defect in the tendon, the pressurized dye will leak upward through the defect.
It just erupts into the space above.
Exactly. The dye fills the subacromial space, or the acromioclavicular region, appearing on the radiograph like a geyser shooting upward. The Geyser sign on an arthrogram is pathognomonic of a full-thickness rotator cuff tear.
The Geyser sign indicates dye leaking into the subacromial space, which is pathognomonic of a full-thickness tear.
Yes.
So we've identified the massive tear. But what happens if the patient is a poor surgical candidate, or maybe they present years late and we just leave that massive tear alone? How does the mechanical failure cascade progress over a decade?
Well, this is where we see the absolute collapse of the centering force couple. Without the supraspinatus compressing the head medially, and without the transverse couple providing a fulcrum, the massive vertical vector of the deltoid takes over completely.
Right, because there's no countermeasure.
Exactly. Every time the patient attempts active forward elevation, the deltoid simply shears the humeral head straight up.
Superior migration. The head just rides north.
It rides north until it literally collides with the coracoacromial arch. Over years, this chronic, unmitigated superior migration leads to a condition called cuff tear arthropathy. The normal space between the humeral head and the acromion, the acromiohumeral interval, which is normally about 7 to 14 millimeters, is completely obliterated.
So in cuff tear arthropathy, you have a 0 acromiohumeral interval on the AP radiograph. The humeral head is literally articulating with the underside of the acromion.
It is. And, bone is highly reactive to abnormal stress. The constant biomechanical grinding of the humeral head against the flat undersurface of the acromion remodels the bone. It hollows out the acromion into a concave, socket-like structure.
It carves out a false joint.
Yes. The terminology for the exam is the acetabularization of the acromion. The acromion begins to look like the acetabulum of the pelvis, and the greater tuberosity of the humerus becomes eroded and femoralized to fit into it.
Superior migration, a 0 acromiohumeral interval, and the acetabularization of the acromion. That is the triad of end-stage cuff tear arthropathy.
Spot on.
So if you only remember one thing from this failure cascade, an anterior dislocation in a patient over 40 means a high suspicion for a cuff tear. The Geyser sign confirms a full-thickness defect, and chronic massive tears result in superior migration and cuff tear arthropathy.
A catastrophic failure of the suspension system. But let's shift to a scenario where the tendon hasn't necessarily torn apart, but the environment around it has become hostile.
That's my pinch. Subacromial impingement.
Right. The term impingement gets thrown around loosely in general practice, but for the FRCS, you need to be extraordinarily precise about what is being compressed and exactly where it's happening.
Okay.
In subacromial impingement, the rotator cuff, specifically the bursal surface of the supraspinatus tendon, is pinched between the humeral head inferiorly and the coracoacromial arch superiorly.
Okay, pinched between the humeral head and the coracoacromial arch. It's an external bursal-sided phenomenon. Now, what drives this mechanically? Is it a bone spur growing down, or is the tendon swelling up?
Well, it can actually be either or both. We classify the acromion morphology, right? Type 1 is flat, type 2 is curved, type 3 is hooked. A type 3 hooked acromion physically narrows the subacromial space.
Makes sense.
But alternatively, if the tendon is inflamed and edematous from overuse, it effectively becomes too thick for the tunnel it has to pass through. Or if the force couple is slightly fatigued, the humeral head rides a millimeter or two higher than normal. Any of these variables lead to the tendon being crushed against the arch during elevation.
And the patient presentation is incredibly specific here. We are looking for a highly localized arc of pain during the physical exam.
The clinical hallmark is the painful arc, occurring strictly between 60 and 120 degrees of active abduction.
A painful arc between 60 and 120 degrees of abduction. But why does it only hurt in that specific 60-degree window? Why aren't they in agony the second they start lifting their arm?
It comes down to the osseous geometry. When the arm is resting at 0 degrees, the greater tuberosity, which is the bony prominence where the supraspinatus attaches, is lateral to the acromion.
Right.
As you begin to abduct from 0 to 60 degrees, there is still adequate clearance. The tuberosity hasn't yet entered the narrowest portion of the subacromial space.
But right at 60 degrees, things get tight.
Exactly. At 60 degrees, the greater tuberosity begins to pass directly beneath the coracoacromial arch. From 60 degrees all the way to 120 degrees, that tuberosity is dragging the inflamed bursa and the supraspinatus tendon relentlessly against the undersurface of the acromion. That is the impingement zone.
Wow, so they wince and compensate through that entire middle arc. But then, past 120 degrees, the pain magically disappears.
Because by 120 degrees, the greater tuberosity has completely cleared the arch. It has passed through the gauntlet and is now medial to the acromion. The physical pressure on the tendon is completely released, and the remainder of the movement up to 180 degrees is pain-free.
So the tuberosity clears the arch at 120 degrees. That mechanical explanation makes the symptoms so much easier to remember.
Definitely.
Now, here is a major exam trap regarding the physical examination of this painful arc. Because in a high-pressure OSCE or multiple-choice scenario, they are going to throw every eponymous shoulder test at you to see if you actually know what tissue you are stressing.
Oh, they love doing that.
And the trap usually revolves around the empty can, or Job test.
Yeah, this is a point of frequent confusion. Let's look at the biomechanics of the empty can, or Job test. The patient abducts the arm to 90 degrees in the scapular plane, then maximally internally rotates the humerus so the thumb points down.
Right, like emptying a can.
Exactly. The examiner then applies downward resistance. Many trainees assume this is an impingement test simply because it elicits pain.
But it's not. What are we actually testing?
The empty can test specifically evaluates supraspinatus strength and tendon integrity.
Right.
By placing the arm in the scapular plane, internally rotating it, you're putting the deltoid at a severe mechanical disadvantage. Meanwhile, you're placing the supraspinatus directly in line to resist the force. It isolates the muscle. It does not diagnose mechanical impingement.
Let me make sure that distinction is locked in. The empty can, or Job test, isolates supraspinatus strength. It does not diagnose impingement. So if Joby tests for strength or a tear, what are the dedicated tests we use to confirm the physical pinching of the subacromial space?
The dedicated tests are designed to intentionally force the greater tuberosity into the coracoacromial arch to provoke the mechanical crush. Those are Neer's test and Hawkins test.
Neer's test and Hawkins test are the dedicated impingement signs. Walk me through the mechanics of those two.
Sure. In Neer's impingement sign, the examiner internally rotates the patient's arm to bring the greater tuberosity forward, and then passively forces the arm into maximum forward elevation. You're deliberately ramming the tuberosity against the anteroinferior acromion. If it reproduces their pain, it's positive.
And Hawkins?
For Hawkins test, you flex the shoulder to 90 degrees, flex the elbow to 90 degrees, and then sharply internally rotate the humerus. This maneuver aggressively drives the greater tuberosity directly under the rigid coracoacromial ligament. Again, you are creating a deliberate mechanical collision.
Job tests the muscle power. Neer and Hawkins test the bony clearance. Now, what about the other name tests that always populate the distractor options? Can we systematically disambiguate them?
Certainly, if you are performing the apprehension tests, where the arm is abducted and externally rotated to see if the patient resists due to a feeling of impending dislocation, you're strictly testing for anterior glenohumeral instability.
Apprehension equals instability.
Got it. If you perform O'Brien's active compression test arm forward, flex to 90, adducted 10 degrees, thumb down against resistance, you are loading the superior labrum. You are hunting for a SLAP lesion or potentially AC joint pathology.
O'Brien's test the labrum for a SLAP lesion.
And if you do the scarf test, also known as the cross-body adduction test, you are passively pulling the arm tightly across the patient's chest. This physically compresses the distal clavicle against the medial acromion, isolating the acromioclavicular, or AC joint.
Scarf test equals the AC joint. Match the vector of the test to the anatomical structure being crushed or stretched.
Exact.
So if a patient has positive Neer and Hawkins tests and a painful arc between 60 and 120 degrees, we diagnose subacromial impingement. Is the treatment a surgical acromioplasty to shave away the bone?
Absolutely not as a first-line measure. Subacromial impingement is overwhelmingly managed conservatively.
Right, because if the impingement is being caused by a fatigued force couple letting the head ride high, cutting bone away doesn't fix the muscle weakness.
Exactly. You must exhaust non-operative modalities.
Yeah.
targeted physiotherapy to rehabilitate the dynamic force couple, NSAIDs, and subacromial corticosteroid injections to reduce bursal inflammation. Surgical subacromial decompression is reserved exclusively for refractory cases that have failed months of robust conservative management.
If you only remember one thing about the outside pinch, subacromial impingement presents with a painful arc between 60 and 120 degrees. The empty can test evaluates supraspinatus strength, while Neer and Hawkins are the true diagnostic impingement tests. Let's take a breath and run through our first mid-episode recap to consolidate this before we move to the overhead athlete.
Sounds good. A necessary pause to ensure the mechanics are clear.
We started with the dynamic force couple. The supraspinatus is active across the entire range of abduction, working with the deltoid, and the front-to-back transverse couple is balanced by the subscapularis anteriorly and the infraspinatus and teres minor posteriorly.
And then we looked at failure. A first-time anterior dislocation in a patient over 40 carries a greater than 30% incidence of a rotator cuff tear. Over 60, that incidence is 80%.
A Geyser sign on an arthrogram showing dye in the subacromial space confirms a full thickness tear.
And chronic massive tears lead to cuff tear arthropathy, superior migration, zero acromiohumeral interval, and acetabularization of the ecremon.
Finally, subacromial impingement produces a painful arc between 60 and 120 degrees of abduction. Job's test evaluates supraspinatus strength, while Neer and Hawkins confirm impingement.
So let's move from the older, degenerative shoulder to the highly torqued athletic shoulder. This is the inside pinch, internal impingement, and GIRD.
So subacromial impingement happens on the outside, the bursal side under the acromial roof. Internal impingement is an entirely different mechanical phenomenon that happens inside the glenohumeral joint.
Right.
And this specifically targets overhead athletes like baseball pitchers, tennis players, javelin throwers.
It is a pathology of extreme repetitive motion. During a pitch or a serve, the shoulder goes through distinct phases, but the critical point of failure occurs in the late cocking phase.
The late cocking position, what does that look like mechanically?
The humerus is in 90 to 110 degrees of abduction, and it is maximally externally rotated. Picture a baseball pitcher just before their arm starts moving forward. The hand is cranked back behind the head as far as it can physiologically go.
And what tissue is getting caught in the hinge in that extreme position?
In that extreme abduction and external rotation, the undersurface of the posterior rotator cuff, the articular side of the infraspinatus and supraspinatus, folds back on itself and is pinched directly against the posterior glenoid labrum.
Let me make sure I have that exact anatomical intersection. Internal impingement pinches the articular side of the posterior cuff against the posterior glenoid labrum.
Correct. It is a posterior intra-articular pinch. But to truly understand it for the exam, you have to understand why it develops. It doesn't happen on the first pitch. It is an acquired pathological cascade caused by the violent forces of the deceleration phase of the throw.
Because after the ball leaves the hand, the arm is whipping forward at thousands of degrees per second, and the posterior shoulder structures have to hit the brakes.
Exactly. The posterior capsule of the shoulder absorbs immense tensile strain during deceleration. Over thousands of repetitions, this tissue undergoes microtrauma. It heals by becoming thicker, fibrotic, and incredibly tight. This acquired contracture of the posterior capsule leads to a vital clinical syndrome known as GIRD.
GIRD stands for glenohumeral internal rotation deficit. The posterior capsule becomes so tight that the patient literally loses the ability to internally rotate the arm compared to their non-throwing side.
Yes, glenohumeral internal rotation deficit. But GIRD isn't just a loss of flexibility. It completely alters the instantaneous center of rotation of the humeral head.
How so? If the back of the capsule is basically a thick, unyielding wall of scar tissue, what happens when the humerus rotates against it?
Imagine the humeral head spinning like a ball in a socket. When the athlete goes into the extreme external rotation of the late cocking phase, that thick, rigid posterior capsule physically blocks the head from rotating in place. Instead, it acts as a cam, actively pushing the humeral head anteriorly and superiorly.
It pushes the head anterosuperiorly. So the GRD, the capsular tightness, is physically shoving the center of rotation upward and backward right into the pinch zone.
Exactly. The posterior tightness drives the internal impingement. The altered kinematics force the articular cuff to crush against the posterior superior labrum.
Which means the treatment strategy has to be entirely different from subacromial impingement. If GRD is the mechanical driver, you can't fix it with a subacromial steroid injection.
It would be absolutely useless. Treatment for internal impingement must aggressively target the GIRD. You have to stretch and lengthen that fibrotic posterior capsule to restore the normal center of rotation. The heavily tested conservative modality for this is the sleeper stretch.
The sleeper stretch targets the posterior capsule.
Yes. The athlete lies on their affected side with the shoulder flexed to 90 degrees and gently pushes the forearm down into internal rotation, stretching out that posterior capsular band. You must correct the internal rotation deficit before you ever consider arthroscopic intervention for the labrum or the cuff.
Okay, I want to cement the difference between these two impingements with a rapid contrast, because in a clinical vignette, you have to sort them instantly. Subacromial is the older patient with a bursal side pinch mid-arc. Internal is the thrower with an articular side pinch on the posterior-superior labrum at extreme range.
That is the exact mental dichotomy you need. Outside versus inside. Degenerative clearance versus kinematic shift.
If you only remember one thing about the inside pinch, internal impingement crushes the articular cuff against the posterior-superior labrum in the cocked throwing position, and it is mechanically driven by GRDD posterior capsular tightness.
Right. So let's shift our focus to the anterior aspect of the shoulder, which brings us to the complexities of the long head of the biceps tendon and its relationship to the subscapularis.
The biceps seatbelt. This is a topic that feels like a constant trap on exams. A patient presents with localized pain right over the bicipital groove in the front of the shoulder. The immediate clinical instinct is to diagnose primary bicipital tendinitis.
And statistically, that instinct is almost always wrong. The most critical epidemiological fact regarding the long head of the biceps is that tendinopathy is overwhelmingly secondary to other pathology. More than 90% of the time, long head biceps tendinopathy is a secondary symptom.
More than 90% of cases are secondary. So isolated primary biceps tendinosis is incredibly rare.
It's a clinical unicorn. The long head of the biceps travels through the rotator interval, which is an area incredibly rich in inflammatory mediators. When the rotator cuff begins to fail, the resulting inflammatory soup bathes the biceps tendon.
Oh, I see.
It is the canary in the coal mine. If the biceps is inflamed and symptomatic, you must aggressively hunt for a rotator cuff tear.
Hunt the rotator cuff if the biceps is angry. But there is a very specific structural link between the biceps and the cuff that goes beyond just shared inflammation. The biceps tendon has to travel down the front of the humerus in the bicipital groove. What stops it from just snapping out of that trench when the arm moves?
Well, it is held in place by a highly specialized sling of tissue, and this is where the anatomy gets really elegant. The primary restraint to medial instability of the long head of the biceps is the subscapularis tendon.
The subscapularis tendon is the primary restraint to medial instability.
Yes, the superior fibers of the subscapularis tendon cross over the bicipital groove to insert on the greater tuberosity, essentially forming a roof over the tendon. It combines with the coracohumeral ligament and the superior glenohumeral ligament to form a reflection pulley system.
So the subscapularis literally acts like a seatbelt. If the bicipital groove is a bucket seat for the tendon, the subscapularis is the seatbelt strapped across it. If that seatbelt snaps, the passenger isn't secure.
That is the exact mechanical consequence. If a patient sustains a tear of the subscapularis, even a partial articular-sided tear of the upper border, the integrity of that reflection pulley is compromised. Without the subscapularis roof, the biceps tendon is free to subluxate or fully dislocate medially out of the groove.
It dislocates medially over the lesser tuberosity. So a patient might present complaining of a painful snapping sensation in the front of their shoulder, which is the biceps sliding in and out of the groove, but the actual primary pathology is a torn subscapularis.
Precisely, which means our physical examination has to differentiate between pain originating from the biceps itself and failure of the subscapularis seatbelt.
Let's lay out the tests. Which ones specifically provoke the biceps?
The classic tests to isolate and provoke the long head of the biceps are Speed's test and Yergason's test.
Speed's test and Yergason's test evaluate the biceps tendon.
In Speed's test, the patient resists forward flexion of the shoulder with an extended elbow and a supinated forearm. Yergason's test involves the patient resisting active supination of the forearm with the elbow flexed at 90 degrees. Both maneuvers tension the biceps tendon in the groove.
So Speed's and Yergason's confirm the biceps is the pain generator. But to test the integrity of the seatbelt, we need to test the subscapularis. What are the tests for that?
To evaluate the subscapularis, you use the lift-off test, the belly press test, and the bear hug test.
The lift-off, belly press, and bear hug tests evaluate the subscapularis. Now, why do we need 3 different tests for one muscle?
Well, because of patient limitations. The classic Gerber liftoff test requires the patient to place the dorsum of their hand behind their lower back and actively push it away against the examiner's resistance.
Okay.
However, if the patient has severe adhesive capsulitis or a massive cuff tear, they may physically lack the internal rotation required to even get their hand behind their back.
So you can't perform the liftoff if they don't have internal rotation. That's where the belly press comes in.
Exactly. For the belly press or Napoleon test, the patient places their hand on their abdomen and pushes inward while keeping their elbow forward of the coronal plane. If the elbow drops backward, it means they are compensating with their posterior deltoid, indicating a subscapularis failure.
It's a brilliant compensatory observation. So if you only remember one thing about this anterior anatomy, biceps tendinopathy is almost always secondary to a cuff tear, and the subscapularis is the primary restraint preventing the biceps from dislocating medially. Speeds and Urgasons for the biceps, lift off, belly press, and bear hug for the subscapularis. Time for our second rapid recap before the final topic.
Good idea. Let's consolidate the internal impingement and anterior structures.
Internal impingement happens in overhead athletes. The articular side of the posterior cuff gets pinched against the posterosuperior labrum in the cocked throwing position.
And it is mechanically driven by GIRD glenohumeral internal rotation deficit caused by a tight posterior capsule shifting the center of rotation.
Biceps tendinopathy is overwhelmingly secondary.
And the subscapularis acts as the seat belt over the bicipital groove. A subscapularis tear allows the long head of the biceps to subluxate medially.
Finally, the clinical tests. Speeds and Urgasons target the biceps, while the liftoff, belly press, and bear hug isolate the subscapularis.
Perfect. Let's move to our final core pathology. Topic 6. The stiff joint. Adhesive capsulitis, which is commonly referred to as frozen shoulder.
The frozen shoulder. Clinically, this is incredibly frustrating for both the patient and the surgeon because it isn't a mechanical tear you can just sew back together. What is happening at a cellular level?
It is a dense fibrotic process. Adhesive capsulitis is characterized by fibroblastic proliferation and an intense contracture of the joint capsule. The glenohumeral capsule is normally a voluminous compliant recess that allows for extreme multidirectional mobility.
Right.
In adhesive capsulitis, inflammatory cytokines trigger myofibroblasts to aggressively lay down collagen, effectively shrink-wrapping the entire joint.
Shrink-wrapping the joint. That perfectly explains the profound stiffness. Now, in the exam, you are going to get a clinical vignette of a patient who simply cannot lift their arm, and you have to differentiate a frozen shoulder from a massive rotator cuff tear, which can present as pseudoparalysis. What is the absolute hallmark discriminator on physical exam?
The clinical discriminator is the assessment of active versus passive motion. A massive rotator cuff tear results in a loss of active motion because the motor unit is disconnected. However, if the examiner lifts the arm, the passive range of motion is largely preserved.
Okay, that makes sense.
In adhesive capsulitis, because the joint itself is shrink-wrapped, there is a global loss of both active and passive range of motion.
A global loss of both active and passive range of motion. If you try to passively lift their arm, you just hit a firm, rubbery mechanical block.
Exactly. Active and passive loss equals a capsular contracture.
Now, are there systemic risk factors? The exam loves to link musculoskeletal pathology to endocrinology.
Oh, absolutely. There are highly testable systemic associations. Adhesive capsulitis is strongly linked to diabetes mellitus, both type 1 and type 2, and thyroid disease, particularly hypothyroidism.
The key systemic associations are diabetes and thyroid disease. Why diabetes? What does blood sugar have to do with the shoulder capsule?
It relates to advanced glycation end products, or AGs. Chronic hyperglycemia leads to the abnormal cross-linking of collagen fibers. This altered collagen is highly resistant to normal degradation, leading to rigid, thickened tissue. The capsular tissue in the shoulder is remarkably sensitive to this metabolic environment.
So a patient with a high HbA1c and a stiff shoulder is textbook adhesive capsulitis. Now, what if we obtain an MRI? What specific anatomical structures show this shrink-wrapping effect?
There are two classic MRI findings you must know. The first involves the axillary recess. Normally, the inferior capsule hangs down in a loose, redundant fold to accommodate elevation. In a frozen shoulder, you see complete obliteration of the normal axillary recess.
Obliteration of the axillary recess. Got it.
The second hallmark is profound thickening and edema at the rotator interval.
Complete loss of the axillary recess and thickening at the rotator interval. How do we approach treatment? I know it has 3 phases, freezing, frozen, and thawing, which suggests it resolves on its own.
It is ultimately a self-limiting condition. But the natural history can take 18 to 24 months, which is agonizing for a patient. Treatment is overwhelmingly conservative. Patient education, supervised physiotherapy, prioritizing gentle stretching, and intra-articular corticosteroid injections to blunt the inflammatory phase.
But what about the recalcitrant cases? If a patient is at 18 months and still severely restricted, what are the surgical interventions?
You have two primary options to break the contracture. The traditional method is a manipulation under anesthesia, or MUA. You anesthetize the patient and use controlled, short lever arm forces to physically tear the fibrotic capsule.
Right.
The alternative is an arthroscopic capsular release, where you use a radiofrequency wand to systematically cut the capsule from the inside.
And if you do the arthroscopic release, you have to be meticulous about releasing that thickened anterior tissue, right?
Absolutely. The surgical pearl is that an arthroscopic capsular release must include a complete division of the rotator interval and the coracohumeral ligament, or the patient will not regain their external rotation.
The release must include the rotator interval. Now wait, we just established that diabetics are highly prone to this due to abnormal collagen cross-linking. Does that change which surgical option we offer them? You wouldn't want to blindly tear abnormally rigid tissue in an MUA, would you?
That is a phenomenal high-level exam nuance. Because the collagen in diabetic patients is so uniquely fibrotic and unyielding, they respond very poorly to blunt manipulation. A manipulation under anesthesia in a diabetic patient carries a nearly 50% failure rate, with rapid recurrence of stiffness and an elevated risk of causing an iatrogenic proximal humerus fracture during the attempt.
Because the bone might break before the capsule tears.
Precisely. Therefore, in diabetic patients with recalcitrant frozen shoulder, an arthroscopic capsular release is the vastly preferred surgical approach. It is controlled, direct, and spares the bone.
That is the exact kind of detail that separates a passing grade from a distinction. If you only remember one thing about the stiff joint. Adhesive capsulitis causes a global loss of both active and passive range of motion. It is heavily associated with diabetes and thyroid disease, and surgical release must include the rotator interval.
A comprehensive breakdown of the mechanics.
And that brings us to the end of the deep dive. We are going to close this out with a lightning round recap, a rapid-fire test of the most heavily tested discriminators from everything we just covered. I'll prompt. You fire back. Ready?
Ready. Let's run it.
Primary dynamic stabilizer nerve roots.
D5 and C6.
Over 40 years old with a first-time anterior dislocation.
Suspect a rotator cuff tear.
The Geyser sign on an arthrogram indicates
A full-thickness rotator cuff tear.
the painful arc degrees for subacromial impingement.
60 to 120 degrees of abduction.
The empty can, or Job test, evaluates what?
Supraspinatus strength.
Yeah.
It does not diagnose impingement.
The dedicated true impingement tests.
Neer's test and Hawkins test.
The exact pathological position for internal impingement.
The late cocked throwing position. Extreme abduction and external rotation.
What drives internal impingement mechanically, and what does it stand for?
GRRD. Glenohumeral internal rotation deficit caused by posterior capsular tightness.
What acts as the primary restraint to medial instability of the biceps tendon?
The subscapularis tendon.
Differentiate the clinical tests for the anterior shoulder.
Speeds and ear gaze songs for the biceps. Lift off, belly press, and bear hug for the subscapularis.
How do you differentiate the lost motion in a frozen shoulder versus a massive cuff tear?
Passive motion is lost in a frozen shoulder, but passive motion is preserved in a cuff tear.
And the two major systemic associations for frozen shoulder.
Diabetes and thyroid disease.
Brilliant. If you take away the core narrative of this entire module, let it be this. The rotator cuff is a mechanical system designed to center the humeral head on the glenoid. If the system degenerates entirely, the head rides superiorly into cuff tear arthropathy. If the clearance is narrowed, the bursal surface gets crushed under the acromion in subacromial impingement.
Right.
And if the posterior capsule tightens and shifts the center of rotation, the articular surface gets crushed in internal impingement. Trace the vectors, understand where the head migrates, and the anatomy will give you the diagnosis every time.
We have spent this entire session focused on how these specific structural failures, a torn tendon, a fibrotic capsule, a hooked acromion, cause the humeral head to migrate and produce acute symptoms. But here is something to mull over before your exam, something beyond the standard multiple-choice questions.
What is it?
How exactly does the central nervous system adapt its motor control to hide these mechanical deficits? How does the brain subconsciously recruit the periscapular stabilizers to alter scapulothoracic rhythm, compensating for a slightly deficient force couple over decades, long before the patient ever physically feels that first painful arc?
The body's remarkable ability to mask its own mechanical decay through dynamic adaptation, well until the system finally collapses. Keep that central force couple in mind, keep studying, and we'll see you on the next deep dive.